The broadcast is now starting. All attendees are in listen-only mode.
Yeah. That was good.
Are people muted?
Try now.
Yeah, the people are muted, so it's on your end.
Try now, Marie. Okay, we're going to try the sound again. Please send us a message if you cannot hear me. Again, this is Bobby Wunsch, and this is the first in a series of discussions about the CBAS home and community-based settings requirements that CMS has provided to the state, and we're going to have a series of discussions about these requirements and a series of questions that we will work on to develop the CBAS transition plan, which will be in accordance and complement the California State Transition Plan. So just as a reminder to everyone, if you want to hear the recording of this meeting after the meeting, you can certainly go to the California Department of Aging website and you'll find the recording. You can also tell others that the recording is available. During the webinar, if you'd like to send in questions at any time or comments, please type them into the question box. And throughout the meeting, we'll stop and hear some of your questions and comments depending on the topic. And then at the end of the webinar, we'll open up the phone lines for comments and questions. First, we want to thank the SCAN Foundation, who's supported many activities related to the CBAS process, the last CBAS stakeholder process about the 1115 waiver, and now this home and community-based settings stakeholder process. We're very appreciative of their support and help. Today, here's what we're going to do today at the meeting. We're going to make sure everybody understands the context for these stakeholder meetings and what the framework is for the CBAS home and community-based settings stakeholder process. We're going to walk through a very high overview of the California statewide transition plan and understand how the CBAS transition plan fits into the statewide plan and will complement it. And then we'll begin a discussion of the exploratory questions that CMS has already posed to the state of California to be answered, and we're looking for input from all of the stakeholders on these questions And they will be incorporated, the answers to these questions will be incorporated into the work plan that will be developed as part of the transition plan. We have a number of meetings scheduled ahead, and we'll look at the schedule of those meetings and those dates in just a minute. Oops. So just to reinforce what we're doing today, and through this process, today we're going to provide an overview of the federal home and community-based settings regulations. We're going to talk with all the CBAS stakeholders about CBAS settings in the context of these new regulations, and then we're going to start the conversation about the CBAS home and community-based settings transition plan and begin to get input as we go through that process. Our goal, remember, is to make sure that the care provided in the CBAS setting is the very best care that we possibly can provide, and we're going to look at ways that the whole CBAS system can be improved over time. So let's stop here and have some opening comments by Ed Long, the Deputy Director of the Long-Term Care and Aging Services Division of the California Department of Aging. Ed?
Good afternoon, everybody. Thank you so much for joining us today as we kick off this process for continuing the work we began with you last spring, where we were engaging you in the process of amending the 1115 waiver and providing us with input into what that waiver amendment would look like for the CBAS program. Through our collective efforts, we were successful in submitting something to CMS, which was acceptable for them, but they had a few questions for us having to do with how the CBAS waiver amendment would address the home and community-based settings rule requirements that had been released in March of last year. And so we've asked you to continue to work with us now to focus on a couple of particular areas having to do with the CBAS Center as an HCB setting, as well as the person-centered planning that takes place in CBAS centers, so that we can submit to CMS by September of this year an updated amendment that includes a transition plan to address the HCB setting requirements and the person-centered care provisions contained in them. So as Bobby mentioned, and as I know John Shen will mention when he is able to join us later, this is not only about the HCB settings rule, but it's also about looking at input from you that will address not only compliance with the requirements of the rule, but also address how do we support the CBAS program in delivering quality services to individuals going forward. And so we are anticipating a very robust and candid discussion with you that will provide us with the information we need to meet our immediate needs for September, as well as look at the future of the program going forward.
Great. Thank you, Ed. And as Ed mentioned, John Shen, the Chief of the Long-Term Care Division for the Department of Health Care Services, will be here soon, and I know you'll hear his voice as we go through the other comments. We also have a host of other CBA and DHCS staff here who no doubt will make comments throughout our discussions today. So each time someone new speaks, they'll announce themselves so you'll know who's speaking at that time. I just want to review quickly the schedule for this CBAS home and community-based settings stakeholder process. We don't have exact dates for the meetings quite yet, but very soon we will. As you all know, this is a very busy season in Sacramento. Many meetings going on, and we just need to make sure that there are no conflicts with the meetings that we're scheduling. So I'm certain that within a few days we'll be able to publish the exact meeting dates for these meetings. All of our meetings will be held from 2 to 5 in the afternoon to accommodate the schedules of the CBAS providers. So we have our first meeting today, which is our kickoff, and we're going to do more than kick off the meeting. We're going to actually get to work before we're done here today. In March, probably in mid-March, we'll have our second meeting, and in mid-April, our third meeting, when we will be working together on the development of the CBAS transition plan. In May, we'll have a fourth meeting, which will be the release of the draft plan, and that will open up a 30-day public comment period on the CBAS transition plan, which will be included in the California statewide transition plan. We expect that in July, after the 30-day period, we'll review the revised plan that will incorporate comments that have been made from stakeholders all over the state. And then it's the intention of the state of California to submit the California statewide plan, which will include the CBAS transition plan, to CMS by September 1st. So we will do our very best, as I said, to get the dates out to you as soon as possible for each of these meetings, and they will be held from 2 to 5 in the afternoon. All will be both in person here in Sacramento, if you'd like to join, or by webinar as we're conducting the meeting today. Okay, I'm going to turn over the discussion to Denise Peach from the California Department of Aging, just to set the context of how we got to talking about the home and community-based settings regulations. Denise?
Sure. Thanks, Bobby. Again, Denise Peach, and I'm the chief of the CBAS branch here at the Department of Aging. And to come back to a couple of points that Ed made about our process getting the waiver amendment for CBAS approved by CMS back in November, we had some sort of last-minute conversations with CMS. We had conversations throughout the process from the time we submitted, but in November we began conversations about how they wanted to see the HCB settings rule entered into this 1115 waiver. And so that's where we got the language that was added here and in the next slide under special terms and conditions at 95C. This is the language that CMS added and that we in California agreed to. And it says basically, can we go back to that slide really quickly? It just says that the state is going to ensure that home and community-based settings have all the qualities required by 42 of the Code of Federal Regulations, and there's the citation that they're applying here, and this is the home and community-based rule that we've been talking about, and other such qualities as the Secretary determines to be appropriate based on the needs of individuals as indicated in the person-centered plan. In a provider-owned or controlled setting, the additional qualities required by, and then there's the other section of the federal rule there that must be met, and we'll talk about these in greater detail when we get into some of our work tools. The state will engage in the CBAS stakeholder process to amend the HCB settings statewide transition plan to ensure that all home and community-based settings found in 1115 have the qualities demonstrated by 42 CFR. The state will amend the statewide transition plan to include the HCBS settings used by individuals in the 1115 and submit the plan to CMS no later than September 1. So, so that's sort of the reason why we're all here is because CMS has asked us to convene the stakeholder session to talk about CBAS and how it meets this HCB settings rule. And on the next slide, the next special terms and condition, this is, again, these are the terms and conditions that are in our 1115 waiver. If you weren't part of those discussions, these were items that were in the waiver that we submitted, and then CMS added some language in here, and we negotiated this language out with them in November of last year. So this STC, 96C, addresses person-centered planning, and it actually addresses the individual plan of care, which we use in the CBAS setting, the care plan tool that we use, and they added the language there in the larger text. The person-centered planning process will, with further development in the CBAS stakeholder process to be completed no later than September 1st, comply with the requirements of 42 CFR. Again, those are the sections of the rule that they're applying here with regards to person-centered planning. And so that it's going to meet these terms and will specify how the plan, in this case not to be confused, managed care plans with individual plans of care. This is the individual plan of care. How the plan will identify each enrollee's preferences, choices and abilities, and the strategies to address those preferences, choices and abilities. How the plan will allow the enrollee to participate fully in treatment or service planning, discussion, or meeting, including the opportunity to involve family, friends, and professionals of the enrollee's choosing. Number 3, how the plan will ensure that the enrollee has informed choices about treatment and service decisions. And number 4, how the planning process will be collaborative, recurring, and involve an ongoing commitment to the enrollee. So those are questions that we'll address and that we have already sort of built into some work tools that we're going to show today and that are in draft and that we hope will work in this process as we explore the other questions that CMS has raised for us. But these are the specific ones to person-centered planning, and some I would just sort of footnote that I think that we already in our ADHC CBAS world are pretty familiar with in individualizing services and allowing participants to participate in the process of their treatment. And so we're going to be talking again about improving upon those processes that are already sort of built into our ADHC CBAS model. But those are the new terms that CMS put into our waiver special terms and conditions. Go to the next slide. Sure. You want to?
Can we wait one more slide and then we'll take comments and questions?
Okay. So finishing our overview here to give you a little bit more background. So what are the deliverables or work products that we need to produce in the CBAS stakeholder process that CMS has asked us to convene? Well, the first, really the only thing we have to produce for September 1 is a transition plan and timeline for CBAS meeting the HCB requirements on this 5-year timeline that CMS is giving the states to apply and transition to meet these rules. So the main thing that we're going to be doing is putting together this plan. There are work products that will be associated with the transition plan, we think, and we'll be talking about some of that today, that will be developed concurrent with the plan. But they're not required to be submitted to CMS and completed by September 1st, but we'll be touching on those work products as we go through developing the plan. But the main reason we're here is to develop this plan, but we know, just like the last time when we talked about the waiver amendment, that we'll talk about a whole lot of other things while we're here. If we could, we want to make sure that we make everybody aware of the documents that we have posted on our website. One of the primary things that we need to be doing in meeting this HCBS, HCB settings rule is to be doing education and outreach, making sure that that everyone is aware of all of the provisions of this new rule and how they apply to these settings. And so this is a page on the CDA website. It's called Key Documents, and there's a whole bunch of information for the stakeholder process. If you click on Key Documents, it'll get you to the 1115 waiver that has the CBAS provisions in it. It'll give you the CBAS waiver requirements that we just reviewed. And then there's a copy of the home and community-based settings final regulations there in that third bullet. So for studying up on what the regulations actually say, the language of them, you can get to them from that third link there. Scrolling down the Centers for Medicare and Medicaid Services banner there, we have more reference documents that they have made available and some additional links. The exploratory questions for non-residential settings, which is what we're going to be talking about again today. And then some questions and answers with regards to that document that CMS has posted. Again, many tools that they've already built into their federal website to help us with understanding what this rule means. And then the CMS Statewide Transition Plan Toolkit. Again, another document that CMS has put together to help states understand how to build these plans and how to deal with the final regulations. So, and then under HCB settings transition plans, we have a link there to California's statewide plan, which is on the DHCS website, and there's a timeline that's associated with that. So we're going to be referencing that and talking about that today, and somebody from DHCS is going to be giving us an overview in just a minute. There's a placeholder right there for the draft CBAS transition plan, so as soon as we begin to start working on some text for that, we'll pop that up there for everybody to see. And then there's some documents here that will elaborate on the stakeholder process and public notice and comments requirements from CMS. And there's also a link here to the DHCS Stakeholder Engagement Initiative, which we're going to talk about next. So if we go back into our presentation, and there is the DHCS Stakeholder Engagement Principles. We just want to mention this briefly to say that the Department of Healthcare Services and CDA are engaged in this process here for the CBAS stakeholder process together. And up on the DHCS website, this is the link to it right here. There's information about the DHCS Stakeholder Engagement Initiative. If you would click, Ryan, right on that under the background there, and it'll pull up a document that has some principles that DHCS has put forth to ensure that we all run our stakeholder processes in a meaningful and transparent way. So there under our stakeholder engagement goals are to provide clear, transparent, regular stakeholder communication coordination in advance and during new initiatives, improve overall communication with stakeholders through outreach efforts, and we'll talk about outreach in just a minute, to reinforce the standard practice of engaging stakeholders in development of policy, ensure each stakeholder has an effort has a clear purpose and scope, et cetera, and identify and implement best practices to share and integrate stakeholder feedback throughout the department. So these are some engagement initiative principles that, again, we wanted to just sort of set as framework that we're paying attention to and following based on feedback providers have given regarding how stakeholder processes can be more clear, transparent, and meaningful. We can pop back out to that, just to that page for just a second, Ryan, and I just want to show a few of the things that are there. There is a meeting calendar down at the bottom. If you scroll all the way down, there are calendar of events that have all the stakeholder processes that are going on. One of the reasons why Bobby had mentioned why we haven't gotten the dates all set yet, because we're all trying to not conflict with dates. So that's one of the calendar management issues that has had us challenged in getting our dates set. And then here are all the stakeholder processes that are underway. So just wanted to mention that we're paying attention to that and following along with those principles with this process as well. And I think that's everything on that overview slide, and that brings us to the next piece or two.
So before we go into the California statewide transition plan, Denise, would you just talk for a minute about outreach for the CBAS process, and then we'll go to some questions and comments.
Thank you. I said I was going to mention that. So, so we have had a little bit of a tight turnaround time on getting everything set this month. So we have done our best to just over the last 2 weeks to reach out and send our message far and wide that we were starting this process, and we want as many to lend their voices to this discussion as possible. We've reached out to all sorts of sectors through our aging network here at the Department of Aging, through our CBAS providers, through CADS, through Disability Rights, National Senior Citizens Law Center, now Justice and Aging. We reached out to the Olmstead Committee, to the ADRC's, Alzheimer's Association, the Mental Health and Aging Coalition, the ARC of California, Family Caregiver Alliance, Caregiver Resource Centers, State Independent Living Centers, lots of folks, CAD-CAM. So we have done our best to get the message far and wide that we were engaging in this process, and we put a lot of information up on our website. We will continue to reach out and let people know about upcoming meetings and invite them to participate in the conversation. So lots more outreach to come, and outreach, by the way, and education is a big part of the transition plan that CMS has asked us to put together, and one of the criteria on which they'll judge our plan. So we want to make sure that for all the right reasons, including that we want CMS to approve this, that we're doing all of this outreach.
Great. Thanks, Denise. And for those of you that are here as stakeholders and on the webinar, feel free to pass on the information about these meetings to others other colleagues, other consumers, other family members, to invite them to join in and participate. So let's just stop for a minute and see if anyone here, any stakeholders in the room here have any comments so far, and then we'll see if there's any comments relevant to the slides that we've shown so far. And if you could introduce yourself, say your name and your organization, and then we'd love to hear your comment. Lydia?
Hi, Lydia Missalides with CATS. Thank you for hosting this meeting. We greatly appreciate the stakeholder process and having you back, Bobby. High-level question for either Denise or Department of Health. With that STC 95C, it kind of reminded me again when you went over it, Denise, that it seems to me it's kind of mixing in CBAS with all home and community-based settings found in the demonstration. So do you guys have thoughts on that language, and are we really talking about everything in the 1115 demonstration waiver? I know MSSP already has a plan either in the works or submitted, or are we really focusing our attention just on CBAS? And one of the things that I know you and I talked about, Denise, was our adult day programs and our sister department, social services. Right. Seems like they would also, even though they're not directly listed in the waiver separately, they are a purchase service under MSSP. So it's kind of these linkages that I'm wondering how far afield we're going to get.
I'll let John take a piece of this, but I want to just say that in a minute we're going to have an overview of the statewide plan, and MSSP is in there because it's a 1915C. Right. But yes, this was something that we certainly had a conversation with CMS about back in November, about the way that this language was written and about our sort of thought that it was in the CBAS section, it ought to be more specific to CBAS. And I'll let John take it from there.
Yeah, this is John Shan. Sorry that I'm a little bit late, but definitely welcome this new stakeholder process for the CBAS. I think basically the CBAS final rules, all the states, including the state of California, is definitely engaging with CMS in a very ongoing conversation in terms of the size and scope of the new CBAS final rules. Officially, the CBAS final rule affects the 1915C, 1915I, and 1915K very specifically. I think CBAS is the first provider in California that's under 1115, and CMS treated as a home and community-based service program and want to apply the same set of CBAS final rule to CBAS. So it's quite unique because in the 1115 waiver, no other provider has been mentioned to require to comply with the final rule. I think they tend to treat CBAS as a home and community-based program as compared to other programs like physician visits and labs and radiology. Those kind of medical services, they have not treated as a home and community-based services. They treat CBAS as a home and community-based services. And I'm sure the CBA has shared with you that we're quite surprised at the last hours of the SDC process that they stick this, suddenly they want this to be complied with the CBAS final rule. So in the sense that we treat CBAS as uniquely under the 1115 to service that need to be complied with the final rule, and we want to take this opportunity, both CBA as well as the HCS, to look at how we can make use of this opportunity to work with the CBAS provider to continue to improve the program, to improve the experience of our consumers through the CBAS program. So at this point, very straightforward answer to the question is basically is only applied to CBAS provider at this time. But we won't know until the ongoing evolution of CMS in this discussion with the different states, what is included, what's not included. Okay.
Thank you, John. Thank you. So we don't have any comments yet from stakeholders on the webinar, so we're going to go on to talk about the California statewide transition plan, and we have with us Jalal Haddad from the Department of Healthcare Services. Jalal, could you make a few comments and make sure that everyone understands the California transition plan?
Sure. Thank you for the opportunity. Good afternoon. I'll keep this brief. I know you have lots to talk about, but I figure the best thing to do is just kind of explain where we're at today with our statewide plan, you've all, I'm sure, read the new rules, and you've read our statewide transition plan. The progress we've made, we were able to do a couple stakeholder calls. We posted a couple drafts to the website, received comments, roughly 250 comments throughout the state from different advocates and providers and even beneficiaries. We have taken those comments in, revised our plan as best we could, and posted for final submission. I should be clear that we haven't received any feedback on our statewide transition plan to date from CMS. So the CBAS process of incorporating the CMS informing us that we would be incorporating CBAS into the statewide plan was news to us. It's the first sort of indirect feedback that we've gotten on the statewide plan. Our assumption is that as the CBAS, as you folks develop your plan for your program, that will be sort of lifting and shifting into the statewide plan the appropriate parts, but at a semi-high level, a higher level than you'll develop in your individual plan. Since we've published the statewide transition plan, we have been engaging stakeholders mostly through the Department of Developmental Services, who has the lion's share of the work here. If you've read the statewide plan, you know they have most HCBS providers that will be under review fall under the DD waiver. And so the DDS has created a robust work group, basically a committee on their own plan, but it will be working in tandem, sort of a guide for the state. We have breakout work groups that have been created, and this is all very new in the last couple weeks. So we're going to be getting into the nitty-gritty very soon. But what we hope to do is develop in the coming months an assessment tool that we can use, and that can be tailored for different programs, including CBAS. It's an assessment tool that the state survey teams, which have a variety of folks will be involved, can go out and do on-site assessments of specifically the settings presumed not to be eligible, which will submit for heightened scrutiny. We're going to be doing a sample approach on a variety of provider types. We're also developing a provider self-survey and a beneficiary self-survey, which will be distributed once we've developed them fully and have had stakeholder input, which all these documents and tools we'll be using will be posted for public comment so that we can get the best, most useful tools possible. We hope to have all these developed in the near future and sent out to sister agencies, stakeholder input, and then distributed through our sister agencies to local providers and their advocate networks, so that we could start the process of actually assessing really where we're at statewide, what sort of compliance issues we'll run into, and we'll begin discussions on how to remediate. I don't know if I should get any more, go into any more detail, but suffice it to say there's a lot of work to be done, and our sister agencies are working very hard, including CDA, DDS, on engaging their stakeholders, their networks, and we will be at DHCS really looking to you all to help us develop these tools that will be used statewide, and as we develop them, we can tailor them to the programs to make them as appropriate and efficient, as useful as possible. And as of now, we have yet to hear back from CMS, as I said before, so we'll definitely be keeping a very open door with all stakeholders, utilizing the DHCS website and our sister agencies and their networks. I could go into any more detail if you have specific questions.
Thanks, Jalal. I think that's great, because what we want to do next is we want to look at the outline of the CBAS transition plan. which I think we want to go back to the slides, Ryan. I don't think we need to do this. To the next slide. We want to look at the CBAS transition plan outline, which is divided into 6 categories that mirror the components of the statewide plan. And these include education and outreach, assessment of statutes, regulations, policies, and other requirements, compliance, determination process for home and community-based settings, the role of person-centered planning, very important to this group, appeals process, and then compliance and monitoring. And so as the CBAS transition plan is built over the course of our next few meetings, these are the components that we will have to, if you will, fill in. Denise, did you want to say anything else about the outline, and then let's go into the CBAS work tool that we want to look at?
I guess I would sort of piggyback on some things that Jalal said and that John hinted at, which is that some of this we're sort of still guessing at because we haven't gotten much feedback from CMS. These categories that we took to mirror the statewide plan are also categories and components that CMS has told us that they are going to be sort of rating our plan based on. They're going to be looking for these components. And then also that Jalal had mentioned that that our plan may be in greater detail than the statewide plan. Not really sure how these plans marry together at the end of this process, but I think it's our expectation that what we will be doing along this way and filling in behind each of these chapters, if you will, is that we're going to be identifying really specific work products, tasks, milestones, who's going to do what, and that it really will look like a plan and something that we have set about to achieve over the next several years. So I think that we are expecting that we're going to be filling in the details. So whether that's what ends up going to CMS or getting woven into the existing statewide plan is still up for discussion, but certainly I think that we're intending to make this a real plan for who does what, when, and how. So,
good. Okay, and I think what all the stakeholders will see is as you send in feedback from meeting to meeting, that your feedback will be recorded on the website and then incorporated as appropriate into the different sections of the work plan and the transition plan. So let's go next to the next slide and see if there's anything more we want to say about the transition tool, the plan tool, Denise, and we'll go into the exploratory questions.
sure. So Ryan, if you could flip to the next slide. Oh, that's the next slide. I'm sorry. We'll stay on the tool. If we could pop out to look at the tool, that would be good. So what we have done in sort of, again, anticipating this discussion starting today and trying to find a starting point for the discussion. What we've tried to do is to develop some tools that we will fill in, kind of like what we did in the waiver amendment discussions where we started carving up the waiver STCs and thinking about them in chunks. This is what we tried to do here. So what we did in this tool, and again, what I think we anticipate in how this process will unfold, as we ask the questions that CMS has posed for us, as we sort of walk through, thinking through each of these areas of the rule that they've asked us to address, that what we will begin to do is fill in the chapters, those 6 chapters that were on that slide. So this tool right here, it reflects California's statewide plan on the left-hand side, and then it'll be, basically we're trying to have the similar material filling in on the right-hand side. So under the chapter of education and outreach, what are the things that we're going to be adding into this section? Well, at first I think we're going to be adding that we're already starting to educate and do our outreach to make people aware of the new rule, to what it means to them, to help to get the information out to the beneficiaries. I think that some of the things that we have sort of given the pre-think on here is how can we produce some tools to get out to our CBAS providers and have them post one-page easy primers up on their walls next to their license, for example, and make the information more readily available to beneficiaries. So we're starting to think through some of those things, and I think that through this process we're going to come up with all sorts of things to fill in here. So my assumption would be, as staff to this process, that we at CDA and DHCS, Jeannie and her colleagues, we will be working together to start filling in some of this information in each of these chapters based on the feedback today, and start getting ready to sort of build into the plan as we're sort of concurrently walking through the questions. So this is just a tool. If you'd scroll down again, Ryan, we have each of the sections. Here's the assessment of statutes, regulations, and policies. The purpose here is that part of what we're being asked to do is to evaluate the program in its current structure and say how well do our current state laws, regulations, policies, etc. Conform to, have the CBAS program conform to these new HCB rules. What might we need to identify for statutory or regulatory reform? Some of the things that some of us already believe need to happen with some of our outdated laws and regulations, and some tweaking and things. And so what we might be doing along the way in this process as we talk about the HCB settings rule and how our current CBAS statutes work, we might be identifying some things that need to be changed, tweaked to bring things up to date. So that's section 2. So again, this is, if you look at the left-hand side, we're not reading through that right now, but this is something that Jalal was indicating, that each of the programs that are identified in the statewide plan, they're going about the same process. Our colleagues over at Developmental Services right now are in a stakeholder process, and they're doing the same thing, looking at their program rules and assessing what might need to be changed. Under section 3 here, the compliance determination process. So we're in the statewide plan. They're looking at all sorts of different settings that are identified in the 1915C and the other waivers. For us, we have CBAS and CBAS alone, and it's how well does CBAS comply with the HCB settings rules. So, so we're going to be looking just at CBAS here, but again, it mirrors the statewide plan and process there. You can keep scrolling down. So you'll see, if you, we're going to have this document posted up on our website. It's not there yet. Wanted to make sure that we talked about it today and took any feedback about making any changes if people thought there were some changes we need to make, and we will put this up on our website and you can sort of look at it. And again, as you think about giving feedback to us, you can actually write things onto a copy of the document and email them to us, or fax them to us, or mail them to us, so that we have the comments directly right in the section where you think we need to be addressing them. Jalal had talked about assessment tools that they've been developing for the statewide plan, assessment tools looking at what are the HCB settings rules, how well did the settings that they're looking at in the statewide plan meet these setting rules, what kinds of self-assessment might the providers in each of these settings be doing, what kinds of assessment might the beneficiaries be using to assess whether the facilities and settings that they're in meet the requirements. That's addressed in this section. Scrolling. And so the entire document, this is basically how the whole document looks like. Each chapter, there's things on the left-hand side that are from the statewide plan, and some corollaries that we probably will have in our plan. I think that's probably enough of an overview.
I think that was good. That was good. So this is our work ahead for everyone. In addition to developing the plan template, we can go on to the next slide. CMS has also, you can go to the next slide, Ryan, thank you. CMS has also provided a set of exploratory questions, which we're going to consider. First, are they appropriate to the CBAS setting? And then, what will our response be to the questions that are appropriate? And we're going to start today working our way through these questions, and we'll show them to you in just a minute. They will help inform the development of the transition plan. So in just a few minutes, we're actually going to start tackling these questions. But let's just go out to that file so we can show the questions, and everyone can just get a sense of what these questions are. If we go on, these are the STCs that we already talked about, 95C and 96C, and some questions related to the individual plan of care. The exploratory questions follow, starting on page 4, and there's a whole series of topics. This one's on access, and a series of questions that will follow. And in just a few minutes after we finish the overview, we're actually going to tackle as many of these questions as we can during today's webinar, and that will help us start the plan development. So again, this document is posted on the website and or will be posted after today's meeting, and you can start filling in your answers and sending them back. You don't have to wait for the meetings. As much as we can do in advance, we'll appreciate it. We'll go through some and give you an idea of how we want to use these questions and which ones are relevant and which ones need to be thought about in a little differently than they are worded. So let's go back out to the slides. Thank you, Ryan. And let's just talk for a minute, Denise, about the work product. So again, remember what we said earlier. What's absolutely due on September 1st is the CBAS plan, the transition plan as part of the California statewide transition plan, and the CBAS timeline for implementation of the plan. In addition, if we're ready, we'll have a number of work products that we can either, we'll start working on through this process, and we'll see how this process unfolds as to how far we get with the work plan, the work product. So let's go on to the next slide. And Denise, maybe just describe these 5 potential areas where work products might be developed as part of the plan.
Okay, sure. So some of the things, again, that we're just looking at the statewide plan and looking to what kinds of things we're mirroring possibly in CBAS. The provider compliance self-assessment. So in the CBAS setting, we have a number of rules that we think that are a number of components of this rule that are already clearly met. But we need to, as part of ensuring that these HCB settings rules are met across the, not just the CBAS setting in general, but each of the individual centers. Part of what we anticipate is that there will be an ongoing review process. The providers will be self-assessing their own compliance with the rule, that will perform a number of functions, including getting providers' perspective, assisting them with best practice development and doing their own work to ensure compliance with ensuring that they provide choices to the beneficiaries, that they include them in the planning processes for care, all sorts of things. So we had imagined that there would be a tool that would be possibly part of a ongoing monitoring process that the CBAS centers use to complete and ask certain questions of themselves about their setting and whether they meet the requirements. Possibly something that could be incorporated into our ongoing monitoring tool that we use here at the Department of Aging. So that's one tool. Including the beneficiaries and caregivers in this process and allowing them to evaluate settings that they're in and ensure that their perspective is taken into account. We expect that we would be developing some kind of a participant caregiver evaluation tool of setting compliance as well. State monitoring tools, I just mentioned that we at CDA in our role in certifying CBAS centers, we do an on-site review at least every 2 years, and we would expect that much of this can be built into our process as well, where we're evaluating the provider's self-assessment of compliance, some participant sampling, caregiver sampling of compliance, or across the board assessment of compliance, and then our own sort of validation of those tools when we're on site doing reviews. We assume that there would be something like that, including, given especially because monitoring ongoing in an ongoing fashion is part of what the plan needs to include. So we imagine that we'll do our state monitoring tool modifications as well. And then the person-centered process tools, that IPC is blatantly is called out in the waiver as wanting, we need to do something with the IPC. We imagine that there will be a revise or some kind of a redoing of the IPC, possibly things that we already have in place that support person-centered care and planning. We have a participation agreement that we don't have a standardized agreement, but we have certain things that providers and beneficiaries agree to upfront for services, and it's one of the tools that we think might be tweaked to again support the person-centered care piece of this new rule. So, so they're just some things that we just sort of had pre-identified, and I'm sure there are a number of other things that people will, as we start talking and this becomes more real to people, that we'll be coming up with.
Great. So before we dig into the exploratory questions, which we're going to do in just a moment, why don't we just stop for a minute and see if there's any comments from stakeholders. First, on the webinar, it sounds like there's no comments so far from stakeholders on the webinar. Any comments from any of the stakeholders here in the room at CDA? Yes, please remind us of your name and your organization.
I'm Gretchen Brixton. I'm the Senior Director of MLTSS at LA Care. You know, it's interesting as I look at the elements of the work plan.
Gretchen, could you just speak up just a little bit, because we have a mic up here. I want to make sure everyone hears you.
Sure.
Thank you.
As I look at the elements of the work plan, it doesn't sound like they're really addressing the role of the health plan. And I know we are taking an increasing role in authorizations and monitoring and oversight of CBAS in collaboration with the state. So I don't know, that would be something maybe I'd just like to see put out on the table as something for us to consider as we go.
Good. I think it would be helpful to have just a minute's discussion on this issue. Very important issue, and I'm so glad you brought it up, because I think everybody needs to understand I mean, we all understand that CBAS is now in the context of managed care. How does that fit in to the CBAS transition plan? So, John, would you like to say a few comments about that? I think this would be very helpful.
I think a lot of the HCBAS final rule relate to the setting and how the setting protect the consumer's privacy, autonomy, and how do we enhance the individual privacy and autonomy and choices and those kind of things. Those are the character of the setting that definitely a contracting entity like a managed care plan need to be aware of. Okay, so that's one piece. The second piece that's probably also included many of our discussion actually start with the prior process of the CBAS stakeholder group on the SDCs, the individual care plan. What does that really mean in terms of individual care plan, and whether the individual care plan is the overall care plan from the managed care plan perspective, or if the individual care plan is a care plan executed at the CBAS center, and how is that to interface. And again, the individual care plan needs to be patient-centered, personal-centered, and try to enhance the autonomy and independence of the individual as much as possible. So I think right now, of course, we are looking at CBAS, and that's why we are very glad that you, as LA Care, the health plan, are participating, as well as other health plans participate on this conversation, because they are linked. One's quality of the CBAS program, and one is really the overall care plan of the individual, which CBAS is a component. So.
Thank you. Lydia, did you want to add something?
Yeah, I just wanted to comment on that, Lydia, miscellaneous. So I'm glad you brought that up, Gretchen, too, because that was kind of my question about how deep does this 1115 waiver requirement really lead us? And I guess one caution I would want to put out there is that with 21 plans now, 22, there might be more coming on, who knows. I think it's going to be really critical that we try to maintain some statewide-ness and not have 22 different ways of doing things, plus the state overlay on top of that, plus, because it just gets to be too challenging and there's too much risk for misinterpretation, miscommunication, and so on. So, yeah, so I guess that would just be one of my cautions as we're going through this process. and we try to be as not prescriptive as possible, but as clear as possible as to what we're talking about. So.
And good advice.
Yeah, and I may have failed to say when I said the outreach. We certainly got did outreach with the plan, so I wanted to make sure that you knew that as well. We got the word out that we were starting this process. When I was talking about work products associated with this plan, and I mentioned the IPC, we did start talking about possibly needing to overhaul the IPC back in the waiver amendment discussions. But I would hope that what we find as we get going is that we can maybe have a smaller group, an advisory group or a work group to start that process of talking about what might we want to do to the individual plan of care to promote more person-centered care. What might we want to do to other tools that we have in the CBAS centers that might promote better care and better care coordination. There's a lot in the new waiver provisions that talk about care coordination. There's a lot of new mandates that you, as the plans, are getting from in your all plan letters and dual plan letters, whatnot, saying that you need to do care coordination. But I think that there's a lot more discussion that needs to happen at the provider at this setting level, CBAS, to talk about what does that look like, and that can be part of the discussion that maybe we can take on in a separate work group that goes sort of concurrent with this process.
Lydia and then Ed.
And that reminds me too that, this is Lydia Mitselides again, that to what the point that John made earlier, CBAS is unique within the 1115 waiver as being called out as an HCBS service. But by its very nature, managed care is in part directing care for the patient. And physicians are writing prescriptions and treatment plans. So it's an HCBS service that has a very strong health medical component. We're going to run into tension, I think, between whatever the CMS people were envisioning around choice and so on versus treatment plans. And I don't know that it's impossible for us to figure it out, but I just kind of, again, to kind of say as we go through this, I think we're going to have to constantly be balancing those things and realizing where we're going to bump up into other rules related to managed care, related to California's rule. I mean, we are the most heavily invested state in managed care in the country. So I'm sure that the CMSers didn't have us in mind when they wrote these regulations. It would have driven them insane. So just another
I think this is a really good reminder about how important it is for us to have the voices of diverse stakeholders as part of this process. And again, just a plug to everyone that's here in the room and on the webinar to submit your thoughts as we go through this process, because whether you submit them on the work plan with the CMS questions, we really do need to hear from everyone so that we can consider all the different perspectives that go into making the most effective CBAS program possible. Ed, you wanted to make a comment?
Well, I think this discussion just highlights how much work there is to do in response to what CMS has asked us to do under the waiver amendment. And so I think when we talk about this sort of balancing approaches, it's important for us to remember that we may not solve these things by September of 2015. What we will have is a plan for developing an idea of how to approach these issues submitted in September with some milestones set for ourselves going out, possibly not to March 2019, but somewhere between September of 15 and March 2019. That's what ultimately this group is about.
Thank you, Ed. Yes, Denise.
And I footnote on that I think that the conversation around the care plan and the person-centered care in particular, if we can start some of those conversations, I know we all have a busy schedule,
precisely.
Concurrent with developing this plan,
right.
It will be helpful to informing the plan. So
Precisely.
Some of the conversation at least needs to happen
Absolutely.
Beforehand.
And so that conversation may lead to, this is where we can get by at this point in time.
That's really
this is where, these are our intervening objectives. before we get to full compliance.
Great. Okay. So we don't have any other comments so far on the webinar. So now we're going to go back, and we're going to get to work now. And we're going to go back and we're going to look at the CMS exploratory questions. Now you see them here, and again, they'll be posted on the website tomorrow so that you can start studying them yourself. We're not exactly sure how this process is going to go, meaning this conversation we're about to have, because the questions are divided into 5 different categories. And the first category is access. The next category is setting selection. And then individual, initiative, autonomy, independence, and life choices. And then facilities. Let me just read that to you all. Facilities, individual choice regarding services and supports. And then we also have the individual plan of care. So our goal is to get your feedback. It may be a little torturous as we go through this, so everybody's got to stay away and bear with us, is really to go through each of these questions that CMS has posed. Consider their appropriateness for the CBAS setting and how they could be used to deliver the best possible quality of care. And there may be some that we just can't answer that aren't appropriate for the CBAS setting. We need to hear that feedback. So we're going to give this a whirl. We're going to try a couple of these questions, see how we do. And if after a couple of them anyone wants to suggest a different approach, we're very open to doing that. This really is intended as a working set of meetings where we get everybody's input. And I think that's how we did the CBAS 1115 waiver, and we got tremendous input from the work group and all the stakeholders that participated. So let's give it a whirl. We're going to start with the access set of questions. And as everyone can see, CMS has provided somewhat of a framework for the access questions. The setting is integrated in and supports full access of individuals receiving Medicaid, home and community-based services to the greater community, including opportunities to seek employment and work in competitive integrated settings, not necessarily relevant for a CBAS participant, engage in community life, that's certainly relevant, control personal resources, and receive services in the community to the same degree of access as individuals not receiving Medicaid, home and community-based services. So given that context, which is not exactly on point for CBAS, but does affect the other home and community-based services that Jalal talked about in the statewide transition plan, let's tackle some of these questions and see if we can offer some thinking. And that's what we're offering here. We're not offering feedback to CMS right now. We're offering our own thinking about these questions so we can create the plan and so that we can reference the CMS questions so they know we paid attention to their guidance. That's important for doing the CMS collaboration. And Director Laura Conley from CDA has a comment to make.
I think particularly in the context of talking about the CBAS program, we may also want to be, as opposed, I mean, the way this matrix is set out is kind of a yes or no, but the broader context is every state is different in terms of its range of home and community-based services and options to persons with disability broadly, and then particular subpopulations specifically. So I think for California, that also needs to be kind of a context in which we respond yes, no, or caveat. We are a state that has a very broad personal care services, self-directed program, in-home supportive services. That is a big context in which many people participate, receiving services in their own home and community. Then they may be attending a CBAS center or in another waiver program as well. So there's a framework of really kind of more, they're not just necessarily attending a CBAS center. In fact, that's probably not the case for most CBAS participants. So that level of community integration, I think, needs to be kind of an overall umbrella in terms of our response to some of these questions. But again, different states, very different types of adult day programs, some very specific for the developmentally disabled population, and sheltered workshop programs come under that category in CMS's thinking. That's different here in California, and so that's a context I think that's important to take into consideration, especially when you hear about the employment reference and competitive employment. I think that's part of the context that's being addressed by CMS.
Thanks, Laura. That's very helpful. So there are 12 exploratory questions related to access. And as I said, we're going to take a few. We'll spend an hour or so doing this. If I see that everyone in the room falls asleep and we have no input from the stakeholders on the webinar, then we'll have to figure out another approach to this.
We do have a comment.
Oh, good. We have a comment. Would you like to read that out?
Yes.
Thank you.
So this is from Kay Huddleston. We have private pay as well as VA participants in our facilities. So I see our activities and therapies are in a community setting seem very relevant. So that's the comment.
Okay, thank you. Thank you for that comment. And that's an important thing to remember for a number of the CBAS programs. Lydia.
And so that raised another thought for me, which is how does the HCBS unit at CMS consider the Medicaid unit at CMS's rules that equally apply to CBAS? So in other words, for all these years, we've been a state option benefit, a medical benefit under the state plan. Medicaid funding has certain expectations that go along with it. And so one example would be many, many years ago, just what popped in my mind, there was a very stern lecture provided to the CBAS providers from Department of Health Care Services Audits and Investigations Branch about field trips. Mm-hmm. They looked very disfavorably upon field trips outside the center. And it also begs the question then of if there's a 4-hour minimum day and every day people have to receive nursing service, care coordination, or everything everyone's familiar with, how does one comply with that in this setting along with some of these other access questions, freedom to move about inside and out of the setting? I mean, people today have the freedom to leave the center if they want to, their choice. Mm-hmm. They're also voluntarily enrolling. So again, I'm just seeing these really huge tensions between the Medicaid rules on that part of this shop and the new HCBS rules, and how we're going to resolve those. I don't know, but again, I'm just kind of freeform contemplating here out loud with all of you. So what if we really came up to an issue where there was just a clear conflict between what our state laws and regs say and what Medicaid says in the 1115 waiver and what these regs say? Who wins on that argument? Do we know?
Well, I think this is John Shen from Department of Healthcare Services. I think basically is that I'm sure that some of this prior conversation or historical conversation is really in people's mind, but I think this is sort of like the day that we need to navigate together through this process. Okay, we don't exactly know the answer. I think one of the simple indications is that Medicare and Medicaid consider themselves as a payer of services. I think the things that they can decide, CMS can decide, is that they don't want to have a federal participation of a particular service. That's probably ultimately what CMS can decide upon, okay? But in terms of the state can definitely do whatever it wants with its own general fund money, okay, and set its own rules and regulation. But as far as the federal government is concerned, their use of the federal money need to promote these kind of final rules in the direction that CMS wants. And I think that's where it comes down to, is really on the issue of federal participation. So what's at risk, okay, of non-complying is about federal participation. Okay, so I think that's trying to put it as simply as possible. But the state definitely has its own requirement for its providers. And I think a very good example is really, I think, what we are experiencing in the residential care facility licensing. The direction of residential care facility licensing is going into the direction of more health and safety consideration and protection of the consumer, which is basically also possibly going against many of these kind of rules. And basically the question is, how do we optimize both the individual's autonomy, privacy, and integration in the community versus where do we apply protections and safety kind of criteria for that individual. So a lot of this is really basically trying to optimizing, and I think a lot in our thinking when we look at some of these rules and regulations, it's always eventually boiled down to the specific population the provider serves, what's appropriate for that provider, and what is the care plan of that individual that can enhance the individual's sense of integration in the community. Okay? That's a long way of saying that CMS do have some control, and it's about money.
And I think as far as the plan goes, we need to provide answers to the questions that CMS has raised. I think all of you know that there's a dance with CMS that goes on for a long time in any waiver situation or in any regulations like this that they put forward. And we have to demonstrate that stakeholders have had input onto these questions and that we've incorporated these questions and CMS's concerns into whatever proposal is sent to CMS as part of the plan in September. So shall we try to tackle a couple of these and see how we do? And let's dig in. And I'm going to do a little editorializing, but if I say the wrong thing, someone needs to tell me. So we're going to start on page 4 in the access section on question 1A. We're just going to walk down these. Let's see how many we can get through in the next few minutes, and then we can decide. We've set up a grid here. These really aren't yes/no questions, although it looks like it's set up that way. We're looking for more conversation and discussion. Again, some may be more relevant than others. So the first question, as you can see, does the setting provide opportunities for regular, meaningful activities in integrated community settings, CBAS, for a period of time desired by the individual? So let's try to formulate an answer, if you will, or some comments to this question. And we have a comment on the webinar.
Yes, we do.
Thank
you.
So
this comment is from Hulka Sharifi. And they say, yes, but not with the regulatory requirements on the ratio. Most centers like ours maintain 1:5 ratio versus 1:16 direct care. It is impossible to serve the population with that ratio. So answer is yes and no.
Right, and I think that's a perfect example of this question, and I'm sure there will be others where it's not a yes/no, or it is a yes/no, it's both. Denise.
And I just was going to say, this is Denise Peach, that we already have noted this feedback. We will modify the tool. It says draft on it, so clearly we need to have the tool be more flexible so we can accommodate the yes, no, NA, what does this mean, somebody get this clarified from CMS, whatever other categories besides yes and no. So we'll modify the tool.
Right.
Laura? So I could be completely off base here, and I'll rely on my colleagues around the table and elsewhere to correct me if I'm not. But I think, again, this is a contextual type question.
Mm-hmm.
Individuals, based on their need and their individual plan of care, may participate daily, less than daily, a couple of hours a day, I mean, I think that's part of the context that needs to be
Right.
identified. They are not living at a CBAS center. They're living in their own home and community. So, I mean, that's kind of the shape that is also needed as part of the response, I think, in terms of providing the context.
Yes, I think that makes a lot of sense. Anybody else have anything they want to add to this one? If not, we're going to try to walk through them rather quickly. Okay, let's look at 1B. Then we'll come back and look at a grouping of them since we're just reading for the first time. So question 1B, does the setting, we're talking here about the CBAS setting, afford opportunities for individual schedules? We've already talked about that. Laura just mentioned that focus on the needs and desires of an individual and an opportunity for individual growth or development. And I think we would say that the whole principle of the CBAS is built on assessing the individual and providing services and supports to them based on their needs. And as Laura said, they may come every day, they may come a couple of times a week. Their individual plan of care is focused on their specific needs. Anybody have anything they want to add to that?
Sure, I'll add something.
Go for
Denise.
it.
So the thing that jumps into my mind is that is on something that John was talking about. How can we, if we say yes to this, and I would be saying yes, how can we move the needle a little bit further? How can we promote better quality? How can we promote better engagement by the participant, the beneficiary, in ensuring that the services, in fact, do meet their needs and desires? And how could we even look down the road to retooling perhaps our individual plan of care to include something that has participant stated goals? And so it kind of links into some of the other things down the road on person-centered care to me, because I think we can do some things that will drive that a little bit further.
Good suggestion. Anyone else? Anything from the webinar participants
Yes,
on
we do have a
question
question.
1B?
I'll try to speak up. I think people are having a hard time hearing me.
Okay.
Question, where does the caregiver assessment come into this? For example, does the schedule question also take into account the schedule of the caregiver?
Great question. That's exactly the kind of commentary we need. I'm wondering if that would be addressed in a different section of the questions. But does anyone else have any feedback in terms of this question? It's a very important issue.
I'm not sure I got it. Can we?
Yeah, do you want to say it
do
again?
Yeah.
Okay.
Yeah. Where does the caregiver assessment come into this? For example, does the schedule question also take into account the schedule of the caregiver?
And this might be the family.
The family member, I was thinking it meant.
So does that have,
No, go ahead, Ed.
right, so this is Ed Long with the Department of Aging. So I guess my question, and perhaps the person who submitted the question could provide us with a little more feedback, does this have to do with the caregiver's schedule versus the CBAS center's schedule and services being available at a time that address both the participants and the caregiver's needs?
So it'd be great if the person who wrote that question could respond to these questions here in the room, just so we can have some more clarification. That's what we're assuming the issue were, and if we've missed the point, please just type in further comments. We'd love to hear those. Okay, well, let's go on to 1C. If I'm going too fast, anyone, please just say so. Does the setting afford opportunities for individuals to have knowledge of or access to information regarding age-appropriate activities? Now, I wouldn't necessarily use these examples. I'm sure there's other examples that we could use. But the real key is, do they have access and knowledge of age-appropriate activities? And who in the setting will facilitate and support their access? We might not choose these specific examples that are listed here for the CBAS population. But I think this is you know, an appropriate question, both age and ability appropriate, we might even say, in terms of the CBAS population.
So we did receive some more feedback.
Good.
The last part of Ed's question fell off, can he repeat? Generally, I'm talking about the caregiver schedule versus the CBAS center.
Okay. I think you clarified what I was after. Sorry I dropped off there. Thank you.
And then we also have another comment. We coordinate with the caregiver. The most important area is access to transportation. Service at our center is available all day, although it could change later, so we do not limit the day to 4 hours. If we do, the answer is no. We cannot accommodate the need of the caregiver.
Yeah, I think that's, you know, that's an important issue to make note of in terms of transportation. Not necessarily focused on these questions, but I think there'll be a point at which we can come back and incorporate that comment in. Thank you. Lydia.
And I would say on 1C that this we can tie to the assessment of instrumental activities of daily living and the support that the center provides in that regard, and compliance with that. And that is what a lot of the work of the social work department is about.
Anybody else have anything on 1C? Okay, let's go on to 1D. Does the setting allow individuals the freedom to move about inside and outside of the setting, as opposed to one restricted room or area within the setting? So this is I think, again, we have to think of this broadly as it relates to the CBAS environment, not necessarily to walking outside onto the street, but within the CBAS setting. So any feedback on 1D?
Well, Ms. Lydia, my puzzlement on this is it CMS's expectation that all centers must serve or find people that are not Medicaid beneficiaries, or is it just the opportunity that exists to serve people who are not Medicaid beneficiaries? It's odd wording.
Well, I think remember that I think, Lydia, relating to the example, for example, and that example may not be relevant necessarily to the first part of the question as it relates to a CBAS center, is how I look at it. Laura?
I think in some of these questions or these items that they're comparing and contrasting the Medicaid population versus the non-Medicaid population, that I don't know how to put this tactfully, a concept that maybe the Medicaid population would be segregated, and perhaps, I mean, so for example, in a nursing home, the number of beds in a room for a population that's Medicaid versus non-Medicaid private pay, that kind of a context that there might be restricted areas for Medicaid versus non-Medicaid in a CBAS center. My guess is, well, I don't know, it's not even a guess. I don't think you would even know walking through, and the majority of the participants are Medicaid beneficiaries, so the context isn't quite the same. That's my interpretation of the question.
Of the example.
Of the example.
That helps a lot. Yeah.
And I think you could interpret the question very directly as, are there different parts of the center that the participant can move in and out of depending on what activities are going on. Again, another way to interpret the same question. Yes, another question or comment from the webinar.
Mm-hmm. So for our population, grouping them is more appropriate. This is participants with Alzheimer's and dementia. Smaller groups and infrastructure design is important. So
right.
Yes.
Good. No, that's a great example.
Yes.
Thank you for suggesting that. That's a great example. Okay, anything else on 1D? Okay, so let's go on to this will be now on page 6. to question 1.
One more.
Oh, good. Great. 1E. We'll have another comment, and then we'll go to 1E.
So this is from Kathy Wagner. We need to protect a vulnerable population. How do we do that when we're expected to have the clients access areas that may not be safe, as for dementia clients, etc.? So,
Yeah, I think, yeah.
Go ahead,
Our
Denise.
Denise,
Any feedback?
Kathy, I think that's a completely valid issue, and I think it's one of our concerns as we talk about this setting. And this is a licensed health facility with people who need, in many cases, supervision and to be protected from the harms that may come if they were to wander out of the facility. So I think that's a very, very real concern with this setting.
A very good point. And I think we'll have to speak in the plan to the different types of populations that are part of the CBAS program. And they have different needs in many cases.
And I think, like Laura said, this is Jean with Department of Health Care Services. Like Laura had said, you're not treating the Medi-Cal people differently than your private pay or VA. You know, you're not keeping certain ones in a small room while other ones are, you know, doing other things. I think it's that they're all sharing the areas that's what's important.
Good. Thank you, Jeannie. Okay, let's go on to 1E. This is page 6. We're still in the access area. Is the setting in the community or in a building located among other residential, private businesses, retail, blah, 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 that facilitates integration with the greater community? I would reread this as, is the facility accessible and easy to get to for the CBAS? I mean, given, you know, in the CBAS setting. I don't know how others would read that. You're really the experts in CBAS. But to me, this is really about, is it easy to access the facility for the family, for the participant? And this goes back to how easy is it to get to the center for the family and the participants. Anybody have anything they want to add to that?
You know, this is Laura, and I think the context, again, for these E and F, particularly from CMS's perspective, is in part related to some of these programs, which either may be sheltered workshops or other kinds of day settings that may be behind large institutions, public institutions, or farmsteads that are out in the country and where there really isn't, I mean, they're very isolated. So just, again, in context, in terms of other settings and various other parts of the state, not to say that California doesn't have rural settings, but just the context.
Yeah, for the CBAS centers and for the participants. Thanks, Laura. Anybody else have anything you want to add on 1E?
We'll just have a comment from
Good.
Daisy Absalon. She says, our center invites the community, for example, school children.
Good. Okay, so that really speaks to 1E and 1F. That's a great segue to 1F. 1F is, does the setting encourage visitors or people from the greater community? And is there evidence that visitors have been present at regular frequency? So that's a great example of encouraging integration with the community. That's a really good example to use. And certainly family members are encouraged to come and visit the program. Any other examples that we might offer to demonstrate 1F? Yes, Lydia.
And I think the regs speak to this, Denise, if I'm not mistaken. Use of volunteers, students, interns, nursing students, medical rotations, lots of interaction with the community. So I think this one is the easy one.
Good, and that would be a great place to cite the regulations if they actually include those comments, because CMS does ask for citations. It's like writing a research paper.
Yeah.
Citations and footnotes. Good, those are great examples. Anything else from folks on the webinar?
Another comment from Kathy Wagner. We provide outside entertainment for our clients 4 times a month.
Perfect, Kathy, that's great. I'm sure CFS will be glad to hear that.
Yeah.
So important.
Yeah.
Okay, good. Well, let's go on to 1G. Thanks, Ryan, which is on page 7. And if anybody's interested in me writing on the board, as I have in past meetings, just yell. But I was thinking I'd spare you as we work our way through this. So 1G, let's see. Yeah, I would say, I can't, well, I'm trying to think of a way to turn 1G into a CBAS relevant question. Do employment settings provide, yeah, I would say 1G would be not relevant. And I think we can say to CMS, this does not apply to the CBAS setting. It obviously applies to other home and community-based settings. Does anyone disagree with that? Good. Maybe we could have a lot of those. We'll get through this fast. Sorry, I didn't say that. 1H. Hope CMS isn't listening. 1H. Okay. In settings where money management is part of the service, does the setting facilitate the opportunity, moving on to the top of page 8, for individuals to have a checking or savings account or other means to access and control his or her funds? So not applicable in the CBAS setting. Does everybody understand why that's the case? Any comments from the webinar on question 1H?
No comment.
Okay, thank you. Okay, well this is good. We can move on. So 1I, does the setting provide individuals with contact information, access to, and training on the use of public transportation, or in our case, transportation? I would say this is where the earlier comment about transportation we might substitute here. Is transportation available either through the family or provided by the center? Obviously, the CBAS participants are not going to be coming on Muni or on BART or on the light rail, most likely. So the centers do provide transportation, and that's certainly a part of an important benefit to the participants. Does anybody have anything you want to add to that? Yes, Lydia?
I would say this might be a good place to bring in the plan responsibilities, where the centers are helping to inform beneficiaries about transportation services available through the plans, as well as in the general, to the general public and the community. So
that's
we
great.
can tie those things together there.
That's terrific. Yeah, what do you think, Gretchen? Do you think that makes sense?
In this,
Good.
absolutely true.
Yeah, that's great. And this is where we can tie in the earlier webinar comment. Any other comments on this 1I? Okay, well, no one's asleep yet. How are you people doing on the webinar? Okay, 1J. I feel like we should have music. We need those that entertainment that Kathy Wagner mentioned. About now. 1J. We really talked about 1J, I think. Obviously, public transportation isn't an issue, and are there resources about how to access the program? And we really did just talk about that, so I think we covered 1J.
And we can talk about paratransit here.
Yes, good point. Okay, so let's go on to 1K. Does the setting assure that tasks and activities are comparable to tasks and activities for people of similar ages who do not receive home and community-based services? Well, in the sense that the setting is as home-like and warm and friendly as possible, it seems to me that obviously you're not going to get the same services outside. I don't know. Ed, do you want to comment on this?
Well, I rather have a question to throw out there to the
Okay,
CBAS providers who are on the line, and Lydia. Because a lot of what CBAS centers are about has to do with assisting people to regain or maintain their ability to do certain functions. the activities related to that may be activities that have to do with what a person might be doing at home. For example, from an occupational therapy standpoint. And that's my understanding. And I know that Jill Youngling at one point in time had a program where focused on assisting people with traumatic brain injury to regain independent living skills related to such things as making shopping lists and going grocery shopping in the community with a volunteer, that sort of thing. So I'm just curious to know how extensive that is in CBAS settings generally.
No feedback yet.
But I think that might be part of the consideration here is, are the activities and tasks that people are engaged in from a therapeutic perspective in a CBAS center, do they correspond to activities that they would continue in the community outside the center?
Well, I guess the occupational therapy
Yes.
services would really be along those lines,
Right.
helping people be able to stay at home and learn whatever skills they're able to do as much as they can at home for themselves and with their families. Lydia?
So I have two thoughts on this one. This is a really, really important question, and I think one of them is, as we're talking about the person-centered care plan and moving a little bit further down the continuum of individuals setting their own goals, which may or may not be medical treatment goals.
Right.
That there's sort of that level of tasks and activities that are enjoyable to the person, so more like, the recreational therapist approach to life. And then I would maybe think about comparing similar, not just similar ages, but similar functional ability. So to your example, Ed, a person in the community who is of a similar functional ability, let's say they've had a stroke, would be getting similar services, just like you described, to what they're receiving in the center. So kind of compare apples and apples that way. So I think if we can think about it with different levels, not levels, kind of
Different settings?
different people. I mean, we serve so many different types of populations, and I think this also speaks to culturally appropriate activities and tasks.
Oh, that's a good point.
Yeah, so this is such a core part of CBAS. I think we can really elaborate on this and make it very rich in terms of what the centers are doing.
Part of this question, too, again, contextually, really has to do with some of CMS concern about what has been happening in states around services with people with developmental disabilities.
Right.
So that's also a lens you need to look at this through.
Yeah, really good point. Yes, from the webinar.
Yes, we are getting some feedback. So from Daisy Absalon, we encourage our participants with center tasks like cleaning the table, setting the table for lunch, and setting aside folders. And then from Kay Huddleston, OT and the activities director work together regarding each person. So for cooking, sewing, cutting, etc. And then from Kathy Wagner, often the MSW deals with clients continuing to go to church or go to shopping, etc. with their family caregiver.
Great. Those are great examples. Thank you. Perfect. All three of those examples were great. Good. Okay, well then let's go on. This is the last question under access. It's on page 10 of the exploratory questions. This is a very easy one, I think, to speak to. Is the setting physically accessible, including everything, to the needs of the individual? And I think this is obviously an essential component of a CBAS center and one that it's reviewed on from many different perspectives. Anybody have anything they want to add on this? This is, a big yes.
Can I add a question?
Please.
So the plans, I don't know, Gretchen, if you know the answer to this, but I know that the plans are required to do physical site inspections at the physician's offices and in certain settings. I don't think they have those same requirements at CBAS centers, but I know that you guys also do some amount of on-site and credentialing and contracting. Does this come into play at all in how you look at
We're
facilities?
actually not required at this point to do a facility site inspection. However, if a center is in distress,
Right.
and there are some issues, we will go out and take a look. So, but we're not routinely monitoring.
Okay. And this wouldn't be the set of components you were looking to?
Yeah.
Good question.
I
Lydia?
know Brenda was, Primo was pilot testing a tool to measure accessibility in the ADA sense of the term. So we might want to make a note to kind of see where that is at in the developmental stages, because there may be something new coming down the road for you guys and for us.
Yeah, Brenda Primo has provided that tool, your friend is on the call, has provided that tool to Medi-Cal Managed Care Division at DHCS for review just this week.
Oh.
It's been tested with four health plans. Its original intent was for the site reviews that are done in the primary care provider offices by the plans. But it certainly could be adapted, I'm sure, in many different ways.
Maybe even into a
Brenda's
self-assessment tool that providers can
yeah,
have.
it definitely could be turned into a self-assessment tool.
Yeah, I'm pretty sure she tested it at some CBAS sites.
She
It was a while ago when I
Yeah,
talked
she
to her
certainly
about
may
that.
have.
Yeah.
I think it originally started.
Jane circulated it really early.
Yeah.
Yeah, so I'm just saying, you kind of note to ourselves, let's kind of see.
Yeah,
what
we
that
can,
is.
well, I don't know that it's ready to be posted or distributed widely, but we can certainly talk about that. Good. Well, that was a great question, Denise. Okay, is everybody up for trying to do a little bit more?
Yeah.
We do have another question.
Oh, great. Thank you.
So with regards to this last section, have centers considered a height adjustable table for those participants on big and tall power wheelchairs?
Is that June? Is that June Kales?
That's from Daisy Absalom.
Okay. Okay.
And then we did have another question or comment with regards to section 1I. So if
Good.
you just scroll back there. So this is from Kay Huddleston. Demand response transportation is available and mobility training is offered to our participants.
Great. Perfect. That's a great feedback on 1I. And then the question on adjustable tables, I think is an important one and certainly part of the physical accessibility for different types of individuals' mobility. Okay, so the next section is called Setting Selection by Participant. Now, I'm just going to give everybody a heads up that at least in my copy, and that starts on page 11, in my copy, page 12 goes to a right to privacy section and then shifts back on page 13 to Setting Selection by Participant. I'm not quite sure what we should do, but we're just going to follow the pages. If that's okay with everyone, even though it's a little mixed up.
It's a draft.
Yeah, it's just a way to keep marching through, and we'll do this for a little longer, and then we'll see how everyone's appetite is for continuing or stopping. But it's really helpful to go through this. This is going to be extremely helpful in terms of preparing for our next meeting in mid-March. So the second section of the CMS exploratory questions, called Setting Selection by Participant, thanks Ed, the setting is selected by the individual from among different setting options, including non-disability specific settings. The setting options are identified and documented in the person-centered plan and are based on the individual's needs and preferences. So I think that's very clear for the CBAS participants. that they can choose the CBAS setting, or they can choose to stay at home or go to some other kind of non-disability specific setting if it's appropriate for them. I guess the question, which we'll get to in a minute, is how often are these options identified and documented in the care plan as to what this person chose or didn't chose. So we can get some feedback on that as we go through the questions. So 2A, does the setting reflect individual needs and preferences, and do its policies ensure informed choice for the individual? Any feedback on question 2A? Seems like that would be a yes. We might want to give some examples of how that's done. Lydia?
This reminds me of the choice process that like MSSP has to employ with their clients, where they can choose MSSP or another care coordinator. I'm not fluent in how that is worded, right, Ben? So this kind of reminds me, I wonder if they're trying to get at something like that, and I wonder if, since the plans are responsible for eligibility determination, again, if we can say that this is being taken care of through that process where they have an array of choices through managed care, through Medicare. I'm probably not articulating that very clearly, but it feels to me like this one is not one where we have to drill down into a lot of minutia, but more the way this works in California is thus.
Well, it would actually be interesting. I think it's a good point, and it relates to 2B and probably 2C also. I guess it would be interesting to hear from LA Care, because they're here in the room, Gretchen and Raphael, to hear for a person that is new to LTSS and is not enrolled in a CBAS setting, but who has been evaluated as to possibly that's an option for them. What kind of maybe you could explain the process that LA Care uses to give these options to the individual consumer and their family. How might you do that at LA Care from the plan perspective? Just that would be helpful, I think, to educate everyone.
I want to make sure I'm understanding the question, so let me try to answer it.
Just answer it.
So if we have a couple ways that we identify people that might be in need of CBAS. So we have a centralized telephone triage unit, and people call into that and ask, tell our staff that they're having issues or their family members mention it, and then we can make an appropriate referral to the CBAS program. The other way that we are identifying people that need CBAS is that we do a health risk assessment on certain members that are identified as high risk. And in many cases, CBAS is an appropriate referral from the health risk assessment, and so we try to make that happen. We also are starting a program where if somebody has actually been identified for a long-term care custodial placement, we ask the facility or the person referring to us to let us know if they've actually referred to CBAS or IHSS first. So we're getting very little feedback on that, but we're giving it our best shot because we think that there might be and there probably is a need for a more aggressive nursing facility diversion program, but this is kind of a first step in trying to at least alert people that there might be another option. So those are some of the things that I can think about. Do you have any, Dr.
Yeah, so LA Care Health Plan has complex case management that's in-house.
Right.
And as part of medical management and care coordination, the team, MLTSS staff sit in that team, and I sit on that team as well. So if someone is addressing an issue, the staff then can read or introduce options for that individual, so that's another way.
Perfect. Yeah, that's great. And this is Raphael, who's the new Medicare Medical Director at LA Care. Glad to have you both here in person. Okay, so it's I think that those are good examples of 2A and 2B. 2B being offering a variety of options to the client. And that could certainly include, as was mentioned by Gretchen, IHSS as well as CBAS and other services that might be available. John?
Yeah, let me add something on the CBAS side. Undoubtedly, when a person participates in CBAS, the person signs an enrollment agreement with the CBAS provider that I'm willing to participate in the CBAS center, and which is also the next step of it is undoubtedly is how many days you attend the center. That's also part of the care plan and stuff like that.
Good.
So from a CBAS provider perspective, they need to execute those kind of agreements and contractual relations with consumer as an indication of consumer choices to participate in CBAS and whatever care plan that's created for them in the CBAS center. Those are important documentation indicating the person has been given the option and they're willingly to participate.
Great examples, John. Thank you. And I think 2C, question 2C.
I have a comment on 2B.
Okay, great. Thank you. Let's hear that.
From Bob Ariel. To the extent that the individual is able to participate in such activities and still qualify for CBAS via their health challenges, they will be given the opportunity to participate in such settings.
Good. Thank you. Thank you, Bob. Good. And then 2C really is what we've been talking about. Does the setting options include the opportunity for the individual to choose to combine more than one service delivery type? So this would include CBAS, IHSS, no doubt a number of other options that the CBAS center might offer, the health plan might offer to the consumer and the family. So I think we've covered 2C. Anything else from the webinar so far? Good, thank you. Okay, now page 12 is an anomaly. It's going to go very quickly, I can tell. It's a very important issue with 2 questions. So we're just going to stick it in here because we're going in order. And it's section 3, but the numbering changes again in a minute. The right to privacy, dignity, respect, freedom from coercion and restraint. And the framework is the setting ensures an individual's rights of privacy, dignity, respect, and freedom from coercion and restraint. And the 2 questions is all information about the individual kept private. And the second question, so this is 3A and 3B, does the setting support individuals who need assistance with their personal, well, these are 2 different things. So let's start with 3A, sorry. So 3A is all information about the individuals kept private. I think that that is definitely part of the CBAS principles and the CBAS operating procedures. Does anybody have anything they want to add to 3A? I think that's a definite
It's just
yes.
really,
And
Denise said to say there's really good support for that in the regulations too.
yeah,
really.
good, right, great. And that's where we would reference the regulations, right, Denise? And then 3B, does the setting support individuals who need assistance with their personal appearance to appear as they desire and as personal assistance provided in private as appropriate? And I'm sure that this also is reinforced and very important at the CBAS centers. And would that wouldn't be reflected in regulation, or would it, Denise?
Well, we have a lot in regulation about ADLs and
IDLs.
yeah,
So that
and,
would fit.
Yeah.
That would. Okay. So that's another place where we can refer to the regulations. Anybody have anything on, this is a very important area, even though there's only 2 questions. Okay, let's see. Okay, so if we move on to page 13, we have more on right to privacy. Thank you, Lynn. The heading is just goofy. So the heading on page 13 says setting selection by participant, but this is really about the right to privacy. This is a continuation. So now we'll look at 3C. And please, if I'm going too fast, let me know.
If we should go back to 3B.
Yes, we can. This is Laura Conley speaking.
Yeah, sorry. In broader conversations about this issue at the national level, issues have been raised about people being groomed, as in haircuts, et cetera, et cetera. I mean, I don't think those happen at CBAS centers, but everyone having the same haircut or everyone having the, so again, in terms of the performing the ADLs and IADLs, you know, being respectful of the individual's preferences or what they wear or, you know, those kinds of, how their hair is done, that kind of thing. So just a caveat in terms of what we might want to say about that. Being respectful.
People live at home and,
Thank
show up
you.
as they show up.
Yeah. So again, underscoring
They don't get a
the
redo at the
No.
makeover. They don't all
And
end
some
up
they do.
looking alike. So again, respect for the individual's preferences and needs. Thanks, Laura, for adding that. Okay, so page 13, we're still on the right to privacy, even though the heading is incorrect. 3C, does the setting assure that staff interacts and communicates with individuals respectfully in a manner in which the person would like to be addressed while providing assistance during the regular course of daily activities? I certainly hope that's a resounding yes in big capital letters. And I'm sure there are policies at each of the CBAS centers reinforcing this, as well as training that we could reference reinforcing this. Would you agree, Lydia?
Yes, and this is, some of these things that we're hitting on are covered beautifully in the person-centered care and practice training materials that Beth and Lynn have provided to us at our, and we're going to actually have them coming back, if I put a little plug, for our spring meeting. We're intending to have them come back to California and do some more training on this. So.
Perfect. Okay, that's great. Anything from the webinar on 3C? Okay. Well, again, tell me if I'm going too fast. 3D, does setting requirements assure that staff does not talk to other staff about individuals in the presence of other persons or in the presence of the individual as if he or she were not present? Again, an important principle, an important training issue for particularly non-professional, but also professional staff working in the centers. And I'm sure this, we could give some examples of policies at the CBAS centers where this is covered. I'm sure this is in writing in center policies and probably along the same lines as 3C.
I think this is, if I could say about it, this is where we could cite also HIPAA rules that apply to our settings that are another set of regs that centers need to be attentive to and comply with. And, so mention that there.
Terrific. Okay, good. So let's go on to 3E. Again, this is still in the right to privacy section. Does the setting policy, so again, at the CBAS Center, does their policy require that the individual and or representative grant informed consent prior to the use of restraints or restrictive interventions and document these interventions in the care plan? So I need some help on this because I don't know how this works at a CBAS Center. Could anybody speak to this issue? About restraints or restrictions? I mean, obviously there's informed consent, I hope.
Right, so restraints, you know, as far as someone who is in a chair, and this is, I'm a little bit out of my depth too, people being supported in chairs, et cetera, but restraints, I think in the traditional sense that people understand restraints is not something that we see in CBAS. So, yeah, I mean, there are supports and things that would, you know, where some of the same considerations would apply. But as far as restraints, as we would see them in, say, a nursing facility, we don't have the same kinds of things here.
Good. Anything from the webinar participants on 3E?
We are getting some feedback from Amanda Sillers. She says, I believe that there's a regulation in Title 22 that addresses restraints.
Aha. Okay. Does anybody know Well, we'll look that up,
Yeah.
Amanda. Thank you, Amanda, for bringing that up. We'll definitely follow up on that and see if it would be relevant to bring into this discussion.
It's a licensing, right?
Yeah, sure it is
It
related
is a
to
license,
licensing, yeah.
Sure.
Okay, good.
Could we for a minute though, restrictive interventions?
Yeah, I don't know what that, I mean, maybe we could hear from some of the folks on the webinar about how they define restrictive interventions and how those are implemented or not in the CBAS setting.
This is Laura, and I'll be just wild here and guessing on this.
For
example, for individuals who might have behavioral issues, a room or some kind of a setting to protect them, isolation or padding, or I'm just trying to think about how that might, or some kind of a garment that keeps, helps them to calm down. That's concept. We may, back to what we were previously talking about, in terms of the postural supports for people in chairs.
Yeah.
We might, want to figure out what the right terminology for that is. I'm not quite sure. But it's,
Yeah, I'm sure there's a word.
to make sure people don't fall out of, whatever kind of chair or wheelchair that they might be in.
And we are getting some feedback on that. Although we do not have anyone on restraint for postural support needs MD certification, so that is not considered as a restraint, but as a support.
Thank you. Great way to. Thank you. That was great phrasing. That was very helpful. Anything else from the webinar on this issue of restrictive
I
interventions?
have a couple things. So we have an area for clients that may elope from the facility.
Right.
And then some people are having some issues with hearing us, so if everyone can speak up so that people can hear us.
Great. Thank you. Yes, Ed.
And again, I think the focus on these things is that one of the concerns would be that you may have a doctor's order for postural support and that it's not in fact used as a restraint for some other purpose. So that what you're doing is consistent with the intent of the intervention, not used differently from the intent.
Great point. Thank you. Okay. Everybody okay so far? We're going to keep going. So we're now on 3F. This is super helpful. Does the setting policy ensure that each individual supports and plans to address behavioral needs are specific to the individual and not the same as everyone else in the setting? Blah, blah, blah. So it seems to me this would be certainly addressed by the individual care plan. Anybody have anything from the webinar that they want to give as an example of 3F, or anyone here in the room? This is very
Maybe Laura
important.
can help us with this too. This specifically seems to speak to behavioral needs.
Yes.
So do you have any context on this one, Laura?
I was still thinking about that at risk of elopement issue. Sorry, I meant to catch up.
Part of this might have to do with agitation on the part of certain persons and having interventions that are appropriate there, that are individualized, and as opposed to some sort of gross approach to people who have who are agitated that may not be appropriate to the individual. That's what occurs to me from the perspective of people who have cognitive impairments, for example.
Good point.
I would agree with that. I mean, I think for some individuals, in the group setting, doing an activity or having someone come in who does loud music, maybe very positive and energizing, but for other individuals that could be very disruptive. So the mix of how do you balance that and have settings that...
I know that in smaller centers, for example, Don Myers Perkey has a quieter area in her center for people who may be subject to being upset by a lot of noise or activity.
Oh, that's a good example too. That's great. I think we have some comment on the webinar.
We have a couple of comments. So one, yes, IPC addresses this. We also are starting to do depression screening on the caregiver. And then next, IPC needs to mention the behavioral approach specific to the individual with behavioral problems.
Right.
And then I don't see these specific needs addressed in the IPCs for members. Some centers are really good, others really struggle with this.
Very good. That's very good feedback, both of those comments. So one of the questions would be how to provide training to the staff on how to address behavioral issues, both address them directly, but also address them in the context of the individual plan of care. Good. Thank you for that feedback. Okay, does anybody have anything else on the right to privacy? Okay, well, we're going to go on, if that's okay, because the more we can get through this, the more work the CDA and DHCS staff will have to do before our next meeting. And I know they appreciate it. And that way, all the participants on the webinar and here in the room can send in other substantive comments. So we're going to move on to page 15 of 20. We're doing great. You guys are so patient. Individual initiative, autonomy, and independence in life choices. And the framework that CMS has provided for this set of exploratory questions, the setting optimizes but does not regiment individual initiative, autonomy, and independence in making life choices, including but not limited to daily activities, physical environment, and with whom to interact. Now again, we want to make sure that we're thinking about this in the context of the CBAS setting, not in all the contexts that home and community-based services exist. Those will be addressed elsewhere. Okay, so 4A, are there gates, Velcro strips, locked doors, fences, and other barriers preventing individuals' entrance to or exit from certain areas of the setting?
Well, there are, and in part, there are requirements, regulatory requirements for there to be so. For example, restricting access to medications. General access to medications. That's one example.
Delayed egress.
Delayed egress.
Gates. Supply.
Cleaning supplies.
Yeah. So this is in regulation. We can refer to the regulations here.
Yeah.
Anyone else have anything they want to add to 4A?
So we have a couple from the webinar. There are wonder guards on exit doors. We have low fencing as higher fencing reflects institutionalization. However, we have issues with elopement.
Right.
Elopement, is that AKA escape?
Wandering.
Wandering.
Out of here.
Yeah, well, hey. Good. Well, that's great feedback. I think that contrast between the low gate and the high gate and what the consequences are is an important issue to think about. Thank you.
And again, this is the sort of thing where you're talking about the setting, but you also need to be cognizant of the people being served through the setting and what their individual needs are as determined through the assessment and what appropriate interventions are as identified through the interdisciplinary team.
And of course that's hard in a certain sense because everyone in the CBAS setting may have somewhat different needs for these kinds of security and protection.
It's Denise, and I'd add to that where we have we have centers that have, say, delayed egress, and we have people who have higher functional level, they certainly understand how delayed egress works. So with being able to keep hands on doors long enough to have it open, if they're going out for a smoke break, let's say, or a walk or something, if they're higher functioning, then they can function higher with those devices.
Those different devices. So that's an opportunity for flexibility depending on the needs.
It doesn't restrict that part of the population, but the folks who need to be protected.
It does. Yes, from the webinar. Thank you.
We have a question from Anna Chung. Can we have access codes for to prevent dementia participants mixed with non-dementia from going out and wandering? And are we allowed to have locked gates which open up to car passages?
So Anna, we can follow up with you with some exact citations, but there are some specific language in the health and safety codes, or is it in what WNI? I can't remember. I think I'm not sure where it is. For secure perimeters, we can send you the information and follow up. So if the facility is using certain kinds of things, and it'll specify what kinds of devices are appropriate, it says what needs to be in place as far as informing family, caregivers, participants of what they're signing off on, being in a facility that has those kinds of devices, and then what kinds of training needs to be in place for staff, et cetera. So it's pretty dense piece of statute that says how you can meet the requirements. But that's different from this HCB thing, because what they're talking about with the HCB settings is that I think that they see that as being restrictive in a negative way, and I think for those of us who know the populations that are served in this program, we would see that as restrictive in a positive way if used appropriately, right? Because we're protecting people who need protection in a health facility.
So that'll be important, I think, to call out in the plan and in the response to CMS for this population in the CBAS setting. Laura and then Lydia.
And I think one of the comments that we have raised previously, and will certainly raise in this section as well, is that for a large segment of the population who attend CBAS centers, without these devices in place, their family members would not feel that they would be safe in a center, and potentially we would be putting them at a risk of institutionalization because they couldn't be served well in a setting, that they couldn't be safe. And there's also a Medicaid requirement in terms of protecting the health and safety of individuals who are in these settings. So I think those are also contextual, and we'll certainly address those as well.
Yeah, great point. Thank you. Lydia.
Well, I was just going to build on that by, it'll come out in the regulations, I think, but that the state fire marshal has approved these, is in charge of inspection, and give that authority as a safety provision.
Yeah, I think that's an additional item that's important to use as documentation here. Okay, let's go on to 4B. I'll read this in a shortened version. Does the setting afford a variety of meaningful activities that are responsive to the goals, interests, and needs of the individual? Does the physical environment support a variety of individual goals and needs? So I think we've talked about that in terms of the variety of different needs of the individual plan of care, the different levels of activities in the setting. Large group activities, small group activities, quiet areas, more active areas. Anything anybody wants to add to 4B?
As a question.
Oh, great.
What do they mean by non-work activities?
Well, I think that this goes back to, the reason I didn't read that word out is that's really more of a reference to other home and community-based settings, not to the CBAS setting. So if you think of the developmental, people with developmental disabilities who might be working and what kinds of activities are available for them, that's not really relevant to this population. So we're trying to adjust the questions for the CBAS setting and the CBAS population. I hope that was helpful to the person on the webinar. Okay, let's go on to 4C. We're now at the top of page 16 of 20. You guys are doing great. Does the setting afford opportunities for individuals to choose with whom to do activities in the setting? And are individuals assigned only to be with a certain group of people? So maybe we could hear about how activities are organized for the individuals. It seems to me that there are opportunities for individuals to access different activities in the center, and as we spoke about earlier, no one's assigned forever to sit in one place or to only associate with a certain group of people who have certain characteristics or conditions. But it'd be nice to hear from some of the stakeholders here in the room or on the webinar about any other comments on this issue.
I'll go.
Please, Denise.
So, yeah, I think that the setting clearly affords the opportunities to choose activities. You know, I guess I would say that I think that there's some work we could do here to do some training, and it's certainly something that we look at in our compliance role here at CDA.
Right.
We look at activities that are structured in such a way that they're not one size fits all. So people with different functional levels are appropriately placed in different activities. But we see plenty of centers that I think could use some help on that. Could use a little bit more work when we have one activity being offered at one time slot, and it may not be as tailored as it needs to be. So I think the regs certainly support that. The regs on activities are really great, actually, about being, working with people on meeting their social needs and their physical needs for exercise, their stimulation needs cognitively. So I think that they're really good. There's good infrastructure there, but I think that there are providers that could use some help with that. So there's some training opportunities there. But in answering just the basic question, does it afford the opportunities? Oh, yeah.
And supported by the regulations.
Yeah, and supported by the regs.
Good. Great. Okay. Oh, yes, we have a comment from the webinar. Great.
We choose a particular home table for our participants based on what the social workers think would work best for them. They certainly can move around and choose other tables or participants with whom to interact. And another comment, only individuals with special diet sit with a one-on-one supervision, high risk. High-risk name badges identify their diet as well, so staff may recognize the special diet again. And then this one everyone's going to love. The only activity we do every day is bingo on fear of death.
You're involved, otherwise.
Awesome. We want to go to that center. They have fun there. Those were great examples. Thank you from the stakeholder on the webinar. Okay, let's go to 4D. Does the setting allow for individuals to have a meal, snacks at the time and place of their choosing? The second part of 4D, does the setting provide for alternative meal or private dining if requested by the individual? 3, do individuals have access to food at any time consistent with individuals in similar or other settings? So I personally don't know anything about this, so I think this is something we could hear some feedback.
I think this was a lift from the residential settings.
Uh-huh.
Yeah.
So it's,
Yeah. So it really doesn't.
not really applicable in CBAS. Is that the general?
As written, I don't think it does.
Well, maybe we could find a way to describe food service in the CBAS centers. It might vary from place to place, but might be.
They do have snacks.
Right.
Yeah, a meal. Don't they have lunch?
And again, a lot of regulations around meals and how they're supposed to be.
Okay, well, let's make sure to, that's how we should answer this one, even though it's not directly appropriate the way it's written.
Yeah, I think a lot of centers will have coffee carts so people can get up and get
I've
coffee
seen
or
that.
tea or water or things like that. But
Good.
I think even Lynn and Beth, weren't you in that session? That
Denise,
Denise, where they talked about how they tried this, and it was an utter failure to have
Snacks.
and meals that whenever everyone wanted them, and they're the person-centered gurus of the country, and it was an abysmal failure. So everyone gets some input from them on this one.
Right, and then there's the regulators like us will come in and say it's inappropriate to have piping hot coffee that people who are unstable on their feet, or big urns of hot, coffee that tip. I mean, it happens. We get incident reports of accidents
you have
like
people
that.
who have choking
People who have burns.
issues.
Joking.
Yeah.
Interesting.
All right, well, this has lots of different perspectives to it. We'll have to answer to. Okay, 4E is easy, I think. Does the setting post or provide information on individual rights? That's required by regulation, so that should be posted in all settings.
In all languages.
In a variety of languages. 4F, does the setting prohibit individuals from engaging in legal activities in a manner different from individuals in similar or the same settings.
Yeah.
God.
Yeah, residential. So we certainly don't allow consuming alcohol. Sorry.
Even if they're private pay.
Even if they're private pay.
And bring their own wine.
I didn't understand the example about voting. That's what threw me off. Does the setting prohibit, oh, I see, individuals from engaging in legal activities?
Right.
So yes, the settings do for the safety of the consumers, and probably by regulation, I would guess.
Mm-hmm.
Yeah.
Voting is a bad example. Yeah. But the alcohol, okay. I was thinking it was going to say something else. Oh, good. We have a couple of comments. I know we're deteriorating here, so we better hear from the stakeholders on the webinar to keep us.
All right. I'm wondering, since alcohol was a question, is smoking allowable? And another one on smoking. This comes up for us around smoking. As we consider ourselves a health facility, we do not allow smoking.
So there's no overt prohibition against smoking in the facilities inside the building. There's smoking, that most centers that have smokers have policies around smoking outside and smoking on schedules, and most centers who have smokers also have good smoking cessation programs, because this is a health facility, so that should be part of the care planning in a reasonable setting. So, but yeah, there's no laws or regulations against the smoking.
In the facility?
Not inside the building, but inside.
But in the CBAS center, smoking's allowed.
On the grounds.
Yeah, but outside.
Right.
Inside.
Okay.
And you have to have policies and procedures
Hope so.
for appropriate supervision.
Right. Yeah. So there must be regulations about this issue.
There's no ADHD regulations that address smoking.
But it's clear as a healthcare facility. Okay, so if you have a healthcare facility, basically you can smoke on the premises of healthcare facility.
Did you say can't?
Cannot.
I don't know. I don't know of any regulations, and we have lots of programs that serve chronically mentally ill participants, and they have smoking, and it's, as Gretchen says, they do it in a manner that's appropriate, where they're supervising people, and they it's not supposed to be sitting and smoking all day long, and certainly smoking cessation should be part of what they're looking at and other health issues, but they don't restrict people from smoking. So
But skilled nursing facilities, it is allowable on the grounds, not in the building. But a health facility could has the right to prohibit smoking on their campus.
Yeah. Most do. That's very interesting. That was a great question, whoever brought up the smoking question. You've got everybody in the room here scratching their heads about how this works.
So this individual says, unfortunately, we do not have any contained outdoor space for their smokers. So that's an issue for them. And then some further feedback. This is a part of patients' rights within reason. Many with behavioral health issues use smoking as a coping method for their behavioral issues, and if you take that away, we'll see increased agitation.
Yeah. I mean, these are great points. Thank you.
This is the population we're talking about.
We're going to have to address these in our response. Thank you for bringing that up. Very good, and for those additional comments. Okay, now we're on question 4G as a girl, bottom of page 18. And if you guys are really good, we're going to get through this. And this is awesome. Or we're going to have to do most of it, because we're not going to do the individual plan of care today, because we have a lot of issues there that we want to spend a lot of time on. 4G, does the setting afford the opportunity for tasks and activities match to the individual's abilities, skills, and desires? I think we would say yes, based on many discussions we've had today. Does anybody have anything they want to add to that? Laura, did you want to add something?
Well, I would say yes, but I think also acknowledge that challenges, and then I'll just talk about the dementia population. When you look at the progression of dementia and early onset, mild, moderate, severe, and trying to establish groups that very different stages, very different kind of activities, that individual plan of care, it's not easy. And then add the mix to that, individuals from diverse communities, speaking diverse languages, et cetera, it's challenging. So, I mean, just to say yes, I mean, is kind of almost cavalier, yes, but certainly, it's a challenging area.
I would add, too, that even sometimes, trying to have activities that are appropriate for men can be a challenge.
Yes.
So we have to take into consideration gender, too.
Yes. That's a really good point, Gretchen. Thank you. Okay, well, let's keep going. So now we're moving into a new area. This is area number 5, and it's called facilitates individual choice regarding services and supports. And we've talked a lot about this already. The framework is the setting facilitates individual choice, apropos of the last set of comments, regarding services and supports and who provides them. Now again, just as a reminder, as we head into this last section, we're focused on the CBAS setting. These questions were developed for a whole array of health and community-based settings. So if everybody is ready, we're going to tackle the last section and call it a day. So 5A was the individual provided a choice regarding the services, provider, and settings, and the opportunity to visit and understand the options. And I think we would say yes, that CBAS is a voluntary program, and people come and visit and see if they like it and talk to the staff and then make a decision. And as we heard from LA Care, beneficiaries are also offered a series of options depending on their situation. Anybody have anything else they want to add to that? No. 5A. Okay, 5B, does the setting afford individuals the opportunity to regularly and periodically update or change their preferences? I guess
It's built into the structure with the 6-month reassessment and a new care plan, and I think this is an area that I at least would like to see us find a way of talking about participation agreements as a routine thing. I know that that's part of what we'll talk about under the 96C requirements. That there's a ongoing sort of participation in the care plan, and we don't have that built into our regulatory structure right now. But I think some way to build that in a little bit more might be good.
That's great. Any other comments on 5B?
There's a question. What preferences are they referring to?
Well, that's a good question. I think we have to think about that in the context of, again, the CBAS setting, not in the context of the greater home and community-based setting. That might be preferences related to what activities they want to participate in, how many days a week they want to come, how many hours they want to come.
And it could also be that a person might choose that they don't want to continue to receive services in a particular CBAS
right.
center.
Yes.
Participation is voluntary.
Yeah, good point.
So you don't like it here.
Or they don't want to do the PT and OT exercise. They want to just do the bingo bar.
Or would they have, this Lydia again, they may be having some challenges with a particular caregiver, HSS worker, or there's other kind of social dynamics going on where
outside of the center.
Right, where the
Outside
center
the
might
center.
be helping them to
Right.
make some changes. I don't know if we need to drill down that deeply on this one. Do you think?
No. Well, it's important, I think, for people to ask questions about what these words mean. It sounds like we have another comment.
Yeah, we have a comment on this. This is from Amanda Stillers. I think a lot of this section can be addressed as we develop the structure of the person-centered care that's required for the waiver.
Yeah, absolutely, Amanda. Thank you. I think we're all thinking the same thing there. Thank you for adding that. Okay, let's look at 5C. 5C has two sections. Does the setting ensure individuals are supported to make decisions and exercise autonomy to the greatest extent possible, meaning based on their own abilities? Does the setting afford the individual the opportunity to participate in activities in an integrated setting in a manner consistent with their preferences and needs? So I think this follows along the conversation that we had in 5A and 5B, unless anyone has anything additional to add. Obviously, these questions have to be really framed in the needs of the CBAS clients and the CBAS setting, different than other other community-based settings.
I get uneasy with the insure versus afford, so does the setting insure it? How does the setting afford it? So there's some wording things that
well, we can certainly change that.
Yeah, stress.
Yeah. Anybody else have anything they want to add on 5C? Okay, everybody hold on. We've got two more. So patient. 5D has two parts. Does the setting policy, meaning the CBAS setting, center policy, ensure the individual is supported in developing plans to support his or her preferences? That's certainly all about the individual plan of care and the person-centered approach. And is the staff knowledgeable about the capabilities, interests, preferences, and needs of the individuals? And obviously this goes to a whole number of issues, particularly related to training of staff, on person-centeredness, on the individual plan of care, and monitoring that staff are soliciting as possible from the participants what their interests are.
Through their assessment process as well.
And the assessment, right, of course. Yeah, great. Okay. Anything else on 5D?
Yes, we have a comment
Oh,
from
great.
Elizabeth Sharma. I agree that this needs to be improved as we look at person-centered care planning, as we don't really see member-specific preferences on the IPCs.
Right.
Aha. Oh, well, that's a great point then. That's very important. Okay, and we're marking these when we talk at our next meeting about the IPC and person-centeredness. We'll come back to a number of these issues that have been brought up today on the webinar. Okay, 5E. Does the setting post or provide information to individuals about how to make a request for additional home and community-based services or change current home and community-based services?
Yeah, that's a good one.
That is a good one.
It's the plan, I guess, that we would look to for that, playing that role, right?
This kind of goes back to that earlier section
Yeah,
that
the context.
I think we spoke to. I mean, it really seemed much more, I forget where it was now. We were talking about the health plan.
The role of the health plan.
The role of the health
and
plan.
providing
And
options.
you think about like the regional centers. I mean, there are components in the system that are more the care planning, the options, counseling level that would then lead to this. I mean, this one seems more tied to that kind of next level up as opposed to the actual service delivery setting.
Good. Lydia?
Here I was thinking maybe we tie this to the services delivered by the social work team, and that they're available on a daily basis to support the individual's needs for additional services, different services as they come up. So I think we could maybe tie it back to that regulation.
Yeah.
Because the centers certainly know their beneficiaries very, very deeply and have good communication with them.
And I think also the point that Laura made about this is a great place for the centers and the health plans to work together to regularly check in with the participants and their families about their preferences and their needs for additional services.
have a comment on 5D.
Okay, great. 5D.
Okay.
Sure.
There's a conflict often between the client that wants the socialization and the doctor or family who wants the therapy or health maintenance.
Yeah, that's a very good point. That exists in both settings,
Yeah.
in the CBAS Center and outside in the rest of the world. Very interesting point. Thank you. Okay, so we've gotten through the for our first round. Obviously, this is going to be reviewed many times by this group. We've gotten through our the CMS questions, with the exception of the questions related to the individual plan of care and all of the discussion we want to have at the next meeting on person-centered care. So we're going to hold that to the next meeting, one, so we can have lots of time to do it. I just want to thank everybody, particularly the people on the webinar, for continuing to stick with us and provide comment, and certainly for the people here. No one fell asleep, and everyone was attentive at providing feedback. This was great. I wasn't sure we'd get through three of them, and we got through all of them. I'm so impressed. So I guess we'll just stop for a minute and see if there are any other comments from, first let's hear from people on the webinar, if anyone has any additional comments before we start to close the meeting, and then we'll see if any of our stakeholders here at CDA have any additional comments, and then we'll talk about next steps. So anyone on the webinar have any additional comments they'd like to make?
There were just some comments on the tool itself, so we can either address it now or we can address it in the summary tool.
The tool itself? Well, I think it would be great to save those comments, if it's okay, as we start to work on the plan. That would be helpful. For the person who suggested those items, we'll definitely follow up with those. They'll be recorded in the notes, and we'll follow up with your comments, so don't feel like they're being forgotten at our next meeting.
Do we want to ask if anybody wants us to open up the line?
Okay.
In case they haven't been able to type?
If anyone would like us to open up the phone line, we can do that. So if you could indicate, well, if you could, how should we do that?
They raise their hand.
Oh, if you want to raise your hand, meaning your computer hand, and let us know if you'd like to make a verbal comment to the to CDA, to the HCS, and to the other stakeholders, both here at CDA and on the webinar. If anybody would like to make a verbal public comment, we would welcome that at this point.
If we can do it technically.
So you have to click on the little hand, and then we can unmute your phone. Okay, so far no one does. We would welcome that. So now, any comments from people, from stakeholders here at CDA that would like to make a public comment at this time? Okay, sounds like everybody has been worn out by our hard work today, which is good. So let's just talk just for a minute. Let's go to the next slide, and we'll go on to the next one, about our what's going to happen next. So as everybody knows, the CDA staff and the DHCS staff are so great to work with on these processes because they do so much work in between the meetings, and they will certainly do that again. Lynn Benjamin from CDA has been taking copious notes, sitting next to me. Her hands are cramping now. She's had so much to write. And a summary of the notes and the meetings will be posted as soon as they're completed in preparation for the next meeting. And then as soon as we can, we will announce the dates of the next meeting. I apologize again that we don't know those at this point. As soon as we do, we will let you know, and they will also get posted on the DHCS Stakeholder Engagement Calendar. We expect to know soon, so we can let you know. But we're anticipating that the March meeting and the April meeting will be sometime in the middle of March and sometime in the middle of April, again from 2 to 5. This same kind of format. You're welcome to come here to CDA or stay in your office or your home and communicate with us over the webinar. If you have written feedback, and we really welcome this, I think everyone will remember from the CBAS 1115 waiver process that we got a lot of written feedback. It was incorporated into a log that the staff kept. We posted the log. We reviewed all the feedback, comments, and questions. It's a great way to get feedback pushed into the process, so please don't hesitate to send your feedback in. And you can see the email address for you to provide your feedback directly to this process. And then we just want to make sure that everybody is subscribed to the CBAS updates, and you'll see on the screen the link to sign up for the CBAS updates. I suspect probably all of you that are with us today on the webinar here are already on that. But if you're not, we'd love to have you, and then you'll get all the regular updates of these meetings and other things related to CBAS that come directly from the California Department of Aging. So let me check in and see, Denise and Jeannie, do we have anything else we should say in terms of next steps?
I had a couple more things that I flagged. I don't know if Lynn has more for me here, but I had that we're going to follow up with Brenda Primo regarding her accessibility tool and find out what the status of that is, so we can give some information on that next time.
She'll be happy to know we talked about it.
Yeah, and then also that we're going to take the feedback from answering all these questions today and draft them in for the version next time. So and we'll create the log and post comments, and then I also just wanted to mention that that if anybody hasn't reviewed some of the, well, somebody was fading in and out of the questions today, or anybody comes new to the process, we want them to sort of look at these questions for next time, because I anticipate that what we'll do is we'll go over what the answers were, and we'll sort of refine things and then start rolling it up into the plan chapters. So as sort of homework between meetings, if we can look into those questions a little further if we haven't. So
okay,
if you haven't gotten enough today.
Good reminder.
Oh yeah, and to the extent that I had mentioned earlier that if people want to, when we load the documents that we're working on today onto the website, if you want to print out a page and just write comments on it or type comments on it, you can give it directly to us in that format, or you can give us the number of a question that you're responding to the degree that people give us, point us in the direction of where their feedback is relating. It'll be helpful to us.
Yeah, great feedback, thank you. Again, we really welcome everybody's feedback, so take it as your homework to work through all of this again and keep providing feedback as we go. We have another comment from the webinar.
We have a question: by what date to submit feedback?
Great question.
Well, I guess up until the last minute before we have our next meeting is technically correct, and throughout this whole process up and through August. But for the purpose of getting prepared for the next meeting, if you can do them, within a week before, up to a week before, you can give us feedback for putting into the documents, and then again, we'll just accept all the regular comments at any old time.
Great question. Thank you for asking that. Lydia, you have another comment?
I have a question. I might have missed this in the summary. Excuse me. Yeah. Denise, were you referring to? I know we're going to talk about the IPC and Person Centered Care next. Were you referencing this education and outreach piece as well as we need to start filling in, or is that going to be more of a staff function?
Well, first of all, anybody who's willing to do that work and wants to give us feedback, I think we'll accept any and all feedback.
Oh, okay.
But I think that our expectation was that we would go through this sort of painful exercise today, so that we could then begin to start putting things, populating that outline there. So you don't need to do that just yet.
Thank you. And thanks for this meeting today.
That was great. Well, so first of all, before we say goodbye, I want to thank everyone all the stakeholders who came here today to CDA and slogged through this with us, and really to thank all the people that were on the webinar and provided comment. It's much harder to slog when you're sitting at your computer with us than to be here in person. So thank you all for sticking with us the whole time. And big thanks to the staff here at CDA who set up the room, who operated all the electronics without fail. They are awesome. And to everybody at CDA and DHCS who are working on this project. You can tell that this is an incredibly knowledgeable and committed group, just like all the people running the centers, to making sure that the care is the very best that can be provided for the participants. So thanks, everybody. The meeting is adjourned. Great job. Thank you.
It's rousing applause.